Well, good morning and welcome everybody to the now 9th annual Innovasis Symposium. Thank you so much to Brent, first of all, and Russ and with the organization for Brent and the Innovasis team for providing a terrific venue. It's really going to allow us to focus on education, but also have some opportunity for recreation and camaraderie and getting to know one another, getting to learn from one another. Who's been here for more than 5 of these now? 5 of the 9. I know good number of people that have consistently come, and I think we've also got a good number of new faces here, and look forward to get to know everybody. Really, we want to try and make this as interactive as a conference as possible. The co-chairs and I, Bobby Callanter, Fred Moe, Jeff Decky, and obviously Russ Wetton, tried to put together a well-balanced program and going through cervical degenerative pathologies, novel interbody fixations, and some novel surfaces, including the HA peak. This afternoon we'll talk about some MIS approaches and some novel type of lateral approaches, and then building into that as well a bit of the business of spine and understanding the healthcare economic environment that we're working in. So again, we've got a terrific faculty as well as participation that represents broad people both geographically and in terms of type of practices. And one of the real beauties of this course, one of the real strengths of this course has really been the ability to learn from one another. So please ask questions, interrupt. We've built plenty of time for discussion into the program as well. So our first session is really going to be talking about patient safety and quality of care. A realm that really pervades everything we consider in spine surgery, be it deformity and big open procedures or MIS surgery. Patient safety certainly is a primary concern. And I'm going to start our session by talking about benchmarks regarding safety as well as some risk stratification considerations. These are my disclosures. In terms of when we think about goals of managing spinal disorders, be it degenerative pathology or be it more complex cervical thoracic or deformity, in general our goals are we want to effectively decompress the neural elements, we want to improve back pain and alignment, we want to get a solid, effective fusion. That's where our biologics and biomaterials are so important, as well as how we're doing the surgery. We want to really improve patient self-assessment of their quality of life, and ultimately that's the metric of quality we're looking for. We want to optimize value, so the idea of quality and cost and making sure that we're doing this in as cost-effective a way as possible. And perhaps most importantly, and underlying all of this, is we want to be safe. We want to make sure that our patients aren't exposed to unnecessary harm, and the balance between the expected risk and the expected benefit of surgery really is the basis for appropriate decision making. So, first our goal is to not do any harm. Risk and the assessment of risk, the assessment of safety, is really an important basis for making an informed choice regarding appropriate care. And specifically, understanding what the expected risk of surgery is awfully important in empowering informed decision-making. We need valid information about the natural history. What's going to happen if we leave this alone? What's going to happen with a patient with cervical myelopathy if we don't intervene? What's going to happen in a patient with a progressive deformity if you don't intervene? And we also need valid information on the expected outcomes. And expected outcomes include both the expected change in health status, but also the risks of care and what's likely to happen both operatively and non-operatively. So we're going to talk about surgical risk as, again, a basis for choosing the appropriateness of care and for informed choice. I'll talk a bit about some risk stratification tools, and I'll show you some tools that I use in my practice and some more work that we're developing now in terms of predictive modeling, and where I think that in the next decade this is really going to be a big part of how we guide our discussions with patients. So when we think of why is risk important, and what is risk? Well, fundamentally, some assessment of safety, some assessment of risk is important as a quality metric. Knowing what our expected complications are is an important quality metric, and where are our observed complications compared to expected, and having a benchmark that's relevant to the invasiveness of different procedures is important. For the payer, the hospital, anybody who's involved in a bundled payment type of assessment, it's awfully important to really know your risk, because now we're sharing risk. The subset of patients who might have a prolonged length of stay, the subset of patients who are likely to have complications or readmissions, we've got direct accountability for that. So if we don't know that, it's awfully difficult to have effective cost expectations and accounting. When to say yes, when to say no, when to say not yet. We'll talk about that a little bit more tomorrow. But in terms of resource allocation, is what are we able to take on as a hospital system, as a healthcare system? What risk can we assume? What potential costs can we assume? And again, with regard to alternative payment models, it's awfully important to know what the cost is, either of caring for a population of patients within an accountable care organization. At UCSF now, we've got about 150,000 patients under an accountable care system. And in that instance, we're accountable for the entire care for those patients, the entire healthcare bucket. More commonly in bundle payments, we're looking more at 90-day intervals. And then finally, with regard to informed consent, informed decision-making for patients, it's really impossible to have shared decision-making without some assessment of what's the risk of what we're undertaking. And in a lot of instances, we're making decisions under conditions of uncertainty. When to decompress and do a limited fusion, when to do more extensive reconstruction. There's a lot of variability in how we might approach common cases. There's a regional variability, there's patient preferences and patient values that are important, and there's a lot of factors that we need to recognize that are quite predictive of both outcome and risk. And variability is also a metric of quality of care. When we have a clear evidence-based approach to what we're doing, then we're going to develop much more consensus and consistency in how we address common problems. And fundamentally, that's based on valid information. Well, within NAS, a lot of you are familiar and have worked on some clinical practice guidelines. Clinical practice guidelines give us some guidance with regard to specific pathologies, so spinal stenosis, lumbar radiculopathy, disc herniation, degenerative spondylolisthesis, a number of position statements that would suggest when is fusion appropriate, when is decompression appropriate, when is an interbody fusion appropriate. A lot of times the level of evidence we see in that is kind of a level B, or uncertain or inadequate evidence. That tends to be pretty pervasive in a lot of the guidance, which really permits a lot of variability in how we approach common problems. We've done some more work recently on appropriate use criteria, and the idea with appropriate use criteria is again, to assess appropriate use under a methodology where we would suggest that fundamentally we're looking at the balance of risk and benefits. So if the expected benefits of care exceed the expected risk, then that's clearly an appropriate intervention. In corollary, if the expected risks of care exceed the benefits, then that would be an inappropriate intervention. And rating different scenarios along the scale can be useful. And we wrote about this a little bit in a couple of different scenarios, in degenerative spondylolisthesis as well as in adult lumbar scoliosis. And some of the drivers consistently of appropriateness are preoperative symptoms. So the more severe preoperative symptoms, the more appropriate surgical intervention tends to be. Patients with progression of deformity, that tend to be a predictor of appropriateness. Sagittal alignment, of course, we all recognize that patients with sagittal malalignment or progressive sagittal malalignment is a driver of appropriateness. And again, the corollary, comorbidities. Patients who with more comorbidities, with more probability of risk, oftentimes that was a driver of surgery being inappropriate. And this appropriateness criteria actually was with a panel that included neurosurgery, orthopedic surgery, family practice, and anesthesia. I think it's awfully important to have those multiple disciplines involved in decision making. Because part of what happens with regard to decision making, and I think this is an important consideration, is a bit of moral hazard can be at risk. And a moral hazard is when you've got a disassociation of risk and benefit. And some of the classic examples are if you drive your car differently if it's insured than if it's not insured, because you don't have the financial liability if you've got insurance. In the banking industry, right, if you're a loan manager, you're protected individually by the risk, so you may benefit from giving a loan, even if it's a high-risk loan, you may benefit from that. And of course, that was the basis of the savings and loan crisis, and what many of you know about Michael Lewis's disclosure with regard to what's happened in some of the financial ruin a decade ago now. when risk and benefit are dissociated, that can be problematic and lead to some perverse decision-making. And in many instances in medicine, what we're dealing with is a situation where we're making recommendations and making assumptions about risk, but we benefit directly from doing surgery in our hospital, doing surgery in our ambulatory care center. And sometimes the patient is the one who's facing a risk. So again, when there's that disassociation, that can lead to some perverse decision-making, and that's where we as a community have to be very much responsible for trying to be accountable for both risks as well as benefit. Again, shared payment systems are changing that. Some examples, George Bernard Shaw, many of you know, is a playwright from the late 19th century, early 20th century, and he wrote The Doctor's Dilemma. Some of you may be familiar with this play, and essentially what he suggested is that the physician is paid for interventions, for healthcare interventions, especially in the 18th century. Many of these healthcare interventions weren't particularly safe. Yet the physician gets compensated for interventions, and in fact gets compensated more for more invasive interventions. And his suggestion here was that that'd be like having the judge and the executioner being one and the same. The executioner gets paid to execute a prisoner, and then the judge decides whether the prisoner should be executed, and what a conflict that can be. So to that end, I really think that part of what improves safety and part of what we built UCSF at a number of centers is an integrated team. We've got our spine surgeons, we've got non-operative care, but we also get involved, our anesthesiologists, our pain management physicians, our neurologists get involved, often primary care doctors, and having a conference with all of these parties involved to discuss cases, to discuss safety, and to discuss appropriateness of intervention. I'm going to wrap this up soon, but I want to talk a bit about complications and risk. When we think about risks of surgery, what are the expected rates of complications? And to some extent, those expected rates have been reported variably, and certainly those expected rates are dependent upon some patient factors as well as the invasiveness of surgery, the type of procedure. But we can measure quality by our observed rates of complications compared to what ought to be expected for matched cases. One of the difficulties tends to be it's difficult to really know what the expected rates ought to be. There's a broad spectrum of reported rates. If we look in the SRS, the M&M committee of the SRS, which I've been the chair of for a number of years, we've published a number of papers looking at complications in the M&M database. And if you actually look at the numbers here, they're pretty modest. Infections in adult deformity surgery were estimated to be less than 2%. If we look at neural injury, again, about 1.5% expected rates of neural injury. But when we look in more rigorous and series, and in this case, patients who underwent 3-column osteotomy for more severe deformity, neural injuries of 23%. Many of you are familiar with the Scully risk study. Or this study done out of the International Spine Study Group, 70% of patients had some complication when they underwent the long fusion for adult deformity surgery. And again, more than 20% of patients had some neural injury. So suddenly these numbers are really quite different and would lead to a very different conversation. So recognizing what are some of the predictive factors, both patient factors as well as surgical factors, especially surgical invasiveness. Some of the tools that I use, I've got on my EMR, when I sign somebody up for surgery, I actually type in .preop-op, it's .preoperative optimization. And I try and avoid doing elective spine surgery on patients with a hemoglobin A1C more than 7.5, with a DEXA with a T-score less than -2.5, with a BMI, for me, for a male more than 35, for a female more than 30, I try and avoid doing elective surgery. That's something that can be optimized. Serum albumin less than 3.5, active smokers, patients taking more than 50 milliequivalents of morphine per day, patients without adequate social support. I don't want to find out post-operatively after doing a major reconstructive surgery that somebody lives alone in a 3-floor walk-up, but if somebody doesn't have a stable housing situation. Then we're doing more work with frailty and some mental health metrics as well. When we think about risk, oftentimes this is just our personal experience. So you remind me of the last person that we did this procedure on, a golly, she had a foot drop after surgery. Golly, she had a prolonged ICU stay, and that's certainly not a very valid way of looking at risk. I think our case conferences and having multiple disciplines at case conferences really helps to quantify this a bit better and be more objective about it. And ultimately what we're moving towards is predictive modeling. So just like we know with certainty it's going to be a bluebird day out there today, we know that based on literally millions of data points with regard to barometric pressures and with regard to what's happening in satellites. Well, there are some early predictive models that can be used in spine surgery. I actually use these in my practice. One, I've got these available as live links, but we don't have time for that right now. But one is the Dartmouth Sport Calculator. Anybody use this with patients with spondylolisthesis or spinal stenosis? But so in real time, you could put in some of the predictor variables that came out of the Sport Calculator, match patients to patients like them from the data set. And this is a link that I won't go into now, but get some information about where the patient is now and what's likely to happen to patients like them with operative and non-operative care. And it really allows some useful information to guide a discussion. Another tool I've used a bit is called the Spine Sage. Anybody use Spine Sage at all? This came out of the University of Washington, and the group there did some very interesting work collecting extensive data on patients and their comorbidities over a 2-year period. And they looked at variables that included age, gender, smoking status, the type of surgical approach, the invasiveness of surgery, some comorbidities. And they were able to actually develop a calculator that was had a very good area under the curve of more than 0.8 of being able to predict length of stay, being able to predict complications. Another one's the NISQIP calculator. So rather than being based on a couple thousand patients, the NISQIP calculator is now based on over 3 million patients. Does anybody use the NISQIP at all? This is also gives some really useful information. So this is the data that goes in, some patient demographic characteristics, some procedure-related information, and then some risk stratification based on comorbidities. And going through this calculator, you could put in this information about, again, the type of procedure that's being done, the patient's comorbidities, and come up with a very useful estimate of what the likely length of stay is, what likely complications are, and infection rates based on a lot of information. And ultimately, what I think is going to be happening over the course of the next years is all the payers will have information from every payer on over 200 million people to be able to say, well, in scenarios like this with your comorbidities, here's what's likely to happen nationwide. And again, it really helps with regard to predicting outcomes. The last one I'll just talk about briefly is this came out of David Flume as well and the group in Seattle. And rather than predicting complications, in this case, actually predicting outcomes. So looking at a large data set, the SCOPE data set in this case, looking at what was the likely outcome in terms of change in ODI score, the numeric rating score for back pain, numeric rating score for leg pain, and showed some very strong prediction between the patient's health insurance, the patient's preoperative disability was actually the major predictor, and also the preoperative diagnosis. So for example, if somebody had a failed back syndrome, they're very unlikely to have improvement of their back pain with further surgery. Whereas in general, patients who were younger, who had primarily radiculopathy, and who had less severe disability were more likely to do well. So I'm going to wrap this up by saying that patient safety ultimately is the primary goal of everything we do, be it degenerative surgery, MIS surgery, deformity surgery, and patient safety has got to be our number one priority. Risk stratification is important in empowering patients as well as surgeons to make informed choice regarding the appropriateness of surgery. And it's based upon, a lot of times, variables that can be difficult to measure, both patient variables as well as surgeon factors. So it's awfully important that we establish a benchmark for safety and for expectations that's appropriate to the invasiveness of surgery. It's also appropriate and risk stratified for the patient. And ultimately, as we move towards accountability of care and towards risk sharing, this is going to become even more of a priority. So I'll end there and introduce our next speaker. And I think next we've got Billy Lavelle is going to come up and talk more about measuring quality and care in both research and non-research practices. So thanks, Billy.